And so I want to welcome you all to this session. Our focus today will be on the California Advanced Primary Care Initiative, or as we affectionately call it, CAPCI. We are very excited today to highlight this work among commercial payers that is designed to shore up primary care in California through alignment, investment, and a standardized approach to data sharing with practices. We've intentionally given this webinar the very hard name of co-opetition because this concept of commercial payers collaborating together is so new that we wanted to jog all your brains to get you thinking in this new frame of mind. This initiative is actually a joint effort by the California Quality Collaborative and the Integrated Healthcare Association that convenes a coalition of large commercial payers to enable primary care practices to transform to a care model that reduces costs and improves quality and equity outcomes. In short, a value-based care model. 4 commercial payers that are competitors in the state of California, which includes Aetna, Blue Shield of California, Elevance, and HealthNet, are actually collaborating through CAPCI to launch a shared value-based payment model pilot. This is an endeavor that, as you can imagine, is complex, it's multifactorial, it involves many different kinds of experts in quality, in contracting, experts in practice transformation, and actuarial science, just to name a few. But most challengingly, this endeavor is crucially about building trust. And it's about building trust among stakeholders that have many years of experience working together that have not yet engendered trust. So as we're having this discussion today, we invite each of you to think about how you can engage and contribute to elevating and advancing the work of this initiative. As you know, we have some really fantastic speakers here today. We have Janie Mulligan from the IHA, Con Nguyen from COSIVA, Lindsay Peterson from CQC, and Kimberly Robinson from Blue Shield of California. And I neglected to introduce myself. I'm Nina Birnbaum. I'm a family physician, and I am the Medical Director for Innovation Acceleration at Blue Shield of California. We are all here today because we care very deeply, so deeply about primary care. And we're not naive. We know the statistics. We know that burnout is at an all-time high, that doctors are leaving the field, primary care doctors, faster than they can be replaced, that access is strained, and that health disparities remain troublingly persistent. Yet we are also here because we are all believers in the potential and the power of primary care to make profound change, not just in the lives of individuals, which is really important, but in the fitness of our entire healthcare system. All right, without further ado, let's take a couple of minutes now just for each of our speakers to give a brief overview of themselves and their role in the California Advanced Primary Care Collaborative. Janie, could we start with you?
Hello, everyone. My name is Janie, and I'm a part of the Integrated Healthcare Association, or IHA. We are a nonprofit business league founded in 1994, so we've been around for over 25 years, and we're very proud to be a trusted source in data in the healthcare industry. We really exist and work towards a more integrated health system that improves quality and affordability for patients in California and beyond. We champion standard ways to measure healthcare performance through our programs, which empower providers and plans to track and improve clinical quality, cost, and value. So my role specifically at IHA is I am the program manager for the California Advanced Primary Care Initiative, or CAPCI, as we know it around the initiative. Our CAPCI team at IHA is part of the broader performance measurement programs, and IHA partners with the California Quality Collaborative on this initiative, and we're really the neutral co-conveners of the key healthcare players that work in this initiative. A little bit about my background. I have been with IHA since early 2023. And prior to that, I spent a little over a decade working at nonprofit healthcare systems in the state of California in the strategy, business development, and digital health space. So thank you for having me here today. I'm really happy and excited to be part of this conversation.
Thank you, Janie. We're thrilled that you're here. All right, Con, can you come on next? And Kimberly, why don't you come on video too? We'll all be here, a little Brady Bunch moment. Con, take it away.
Hi, good afternoon, everyone. Conwyn, I'm a pharmacist by training, and I'm also the CEO of COZIVA. A little bit about COZIVA, we pride ourselves as the operating system for value-based care. So we have over a decade of experience bringing payers and providers on a single common reporting platform, focusing on population health, quality improvement, performance management, as well as reporting, and all things related to value-based care. So not just focusing on quality, but also utilization management, health equity, patient experience, etc. So that's a little bit about COZIVA as a platform. We've been in California for quite some time, since 2015. But over across the nation, we support 20 million plus active patients today in the current year. And our footprint spans across 22 states right now and rapidly growing. We have about 47,000 providers and provider practice delegates on our platform. And it is widely adopted across the 22 states that we're in right now. So really excited to be part of this collaborative, really excited to be here today and to share a little bit more about COZIVA's role in CAPCI. Back to you, Nina.
Thank you, Con. Great to have you here as well. All right, let's go to Lindsay Peterson next.
Hello, good afternoon. My name is Lindsay Peterson. I'm a senior manager for care transformation at the California Quality Collaborative, or the CQC. And CQC is a program within the Purchaser Business Group on Health that drives improvements in the outpatient delivery system throughout California through multi-payer alignment and through technical assistance. As co-lead for the California Advanced Primary Care Initiative, we bring a lens for strategy, stakeholder priority in California, especially for large purchasers, policy, and a practice transformation lens. A little more about me is I've previously worked at a health plan and at one of the large public purchasers in the state, covered California. And so I'm excited to be able to bring that lens to this project as well.
Well, let's do some background on CAPCI and really talk a little bit about the work already underway. And this is where we get excited to talk about the work that we're already doing. I'd like to call on both Janie and Lindsay because you've been integrally involved every step of the way through CAPCI. So Janie, could you start by telling us about IHA's longstanding involvement in promoting comprehensive care and really driving to outcomes, care that's based on numbers? And about how you're utilizing that experience to support this work, and including measure alignment, which is a key piece of this work. And then, Lindsay, could you take it from there by talking about CQC's role and how you can support practice success in this new team-based, whole person aligned environment? And then Kimberly, after they're done, we're going to bring you on for intros, okay? Perfect.
Thank you. So I would love to just start with a little brief overview and history of the initiative. Both CQC and IHA have been in this space for a long time, really building consensus towards this initiative taking place. We've worked with system partners to develop shared standards, including advanced primary care practice attributes and a performance measure set specifically for primary care. IHA has been in this space for a long time in data aggregation, really bringing to the table our unique and trusted position in measurement and standardization. And along with CQC's strong expertise in history and advanced primary care too, especially in the attributes and also the technical assistance page, really are well positioned to be the neutral conveners that bring these stakeholders together. And we're so excited to do so. And just going over a little bit more background, the MOU was signed in 2022, and 7 payers really agreed to take this on and focus to strengthen primary care in California. And this is a multi-payer initiative, and we seek to enable change and transformation in primary care. And there are 4 main commitments to scaling advanced primary care that is really a part of this initiative. So first of all, transparency, and that's through measurement and public reporting. And this includes, measuring primary care spend and making sure that that information is available, working towards primary care payment alignment and increase investment in primary care, which is really part of the payment model demonstration that will be taking place later this year. And then practice transformation driven by this increased investment. So together, we have really spent, over a year developing this payment model together. And it's unique, and it includes payment for direct patient care plus an additional regular payment to support population health activities and a performance-based incentive based on a standard measure set. So this will be implemented as a demonstration project starting later this year and running through 2025. It involves 4 commercial payers, and it will include up to 30 small to medium private practices in the state of California. We're initially focusing on Southern California and Central California. And while it'll be, tested in the commercial PPO space, it's really meant to be, payer agnostic. And there are pieces of it and just shared measurement using a also payer agnostic common reporting platform. And we're really coming together to illustrate something we already all believe. And that's if you invest more dollars into these primary care practices, quality improve, but patient and provider satisfaction will improve. And so I think, the question is, why do this all together? We get that a lot. Like, competitors, why are they coming together to do this? And really just honing in on that, if you look at a small primary care practice, they have several contracts with different payers, different payer types. These contracts can include different types of payment, different standards, different ways to define good care. And this makes it very complicated for these practices. It can be such a large administrative burden to administer great care under all these different contracts, all these different stipulations. And so when multiple payers come together and align, we can really impact a larger percent of a panel at one of these, or several of these small primary care practices, which really makes change easier for providers and the practice administrators. And the last thing I'll note, I think I mentioned this a little bit. Yes, we're initially testing in the commercial PPO space, but the payment model, the measurement, the common reporting platform, they can be applied to other payer spaces. And we really want to increase alignment. And in order to make lasting change for primary care practices, this needs to be, more than just the commercial space. It needs to extend to other payer types and different spaces. And, it sounds a little cheesy, but together we really can achieve more.
It's so true. Lindsay, take us into technical assistance and talk us through a little bit about that and the role of CQC.
Sure. So CQC has been running successful technical assistance programs for over 20 years. And from our view on the ground, we had used those learnings to convene stakeholders to commonly define advanced primary care through attributes, because you can't scale what hasn't been defined yet. And I'll note, I see in the chat a question, some of those attributes. So what are we talking about when we're talking about advanced primary care? Person and family centered care, care that is integrated, that is team-based with multidisciplinary folks on the same team to cover the various areas of care somebody might need. Relationship-based, accessible, so a variety of ways somebody can access their care, comprehensive and equitable. We can put them in the chat later. I'll note, so we brought stakeholders together and came up with this definition, but we also looked at what are the biggest barriers to scaling this type of advanced primary care. And the biggest barrier that kept coming up was payment. And both that there was not enough, and that also payments based on volume that were not flexible to take care of all the in-between work that it really takes to manage a patient panel, that was not adequate. So that changing payment to consistently invest more into primary care and provide it upfront and flexibly gives practices the resources to sustain improvements that they would gain from a short-term TA program. So that is what we had learned. And this foundational work plus IHA's pioneering work on the measurement space for primary care led to the joint forming of this initiative. And we each brought unique precursor work to help create multi-payer innovation. So it's quite exciting. As Jeannie referenced, the healthcare system has many layers. And what this means is that many practices on the ground likely have many contracts they're managing. They can't keep track of which patient is part of which insurance company or IPA, and which measures and reporting cadence and whatnot are tied to that person. They're likely to be very busy and under-resourced, and so it creates additional administrative burden for them. And so multiple plans working together to pay more and differently upfront is going to help improve operations in a sustained way, so that more of their patients can be paid under the same model. So as Jeannie mentioned, also we can literally help our patients more by doing this together. And also part of the payment demo that was referenced is not just providing dollars, but providing technical assistance in a shared way across all the plans to the same practices so they can get the most out of the payment model. One other thing I'll note unique to the purchaser piece is I wanted to put the broad system alignment in context. So just as providers work with many health plans also have many products and lines of business. And the purchaser business group on health partners with large public purchasers like CalPERS that handles healthcare for all the state employees, and also independent private companies like eBay. So we take a look at their priorities, goals, incentives, and we try to make sure that they are in sync with the plans that we're working with to the extent possible, so that we're really supporting the point of care and amplifying our efforts and not detracting from them. And an example of that is child wellness, for example. So the childhood immunization HEDIS measure is in our common measure set that we've adopted. Purchasers have adopted that into their contracts with health plans. So that HEDIS measure is a priority for purchasers. It's a priority for plans because it's included in part of the payment model as a way that the plans will pay more for strong performance on that measure. And the providers know that if they do well on that measure, they'll be paid more for being successful as a key indicator for managing a population panel.
That's great. The two of you covered so much ground there. One theme I just heard consistently coming out of what you said is about alignment and the complexity of alignment among plans, between plans and purchasers. There's private purchasers, there's state purchasers, and then looking at practices and IPAs and large systems. There's all these levels and complexities of alignment. So Kimberly, I want you to have a minute to introduce yourself and tell folks about your role at Blue Shield and your role in CAPCI. But as you're talking, if you want to reflect on sort of that theme of alignment, I'd love to hear your thoughts on that too.
Absolutely, and it's exciting. So I'm Kimberly Robinson. I'm so sorry about my technical difficulties. All of a sudden, everything froze on me. But I am the Senior Director of Provider Partnerships, and I'm responsible for value-based arrangements and strategic initiatives and the relationship with our providers. And but what's really exciting is being a part of Blue Shield. Blue Shield is really excited from a leadership perspective to invest in the advancement of primary care. It's been a priority for us for quite some time, but then to have the opportunity to do this work with other health plans has made the experience, as we've said, level up. We've done some great work together. And so, Nina, to your question just about the alignment, I mean, this work has been lots of work put in and lots of time. And you can imagine bringing multiple health plans together. There were multiple incentives and desires, and we had to get to a place where we all agreed that we wanted to end up in the same place. And that's the work we do together. And we all have decided together that primary care is the one area that we can influence not only health outcomes, but quality, member experience, access. And so if we don't take care of our primary care providers, we all as an industry will suffer, but most importantly, our patients will. So that's part of the alignment. And then, looking at the cost of healthcare, we've got to do something different. And it all starts in that room with our primary care physicians. We recognize that, for our network providers, that they're experiencing more and more administrative burdens and being asked to do more with little. And in order to make a difference, we're going to have to invest. We're going to have to give them the resources that maybe they didn't have before. And then from our members' perspective, you think about how hard it is right now since the pandemic to be able to access primary care and get into our physician offices. Well, that speaks to what you said earlier about the fact that we're losing our primary care providers, and so we need to empower and invest in them, and that's what we're here to do with this work. And then we want to also talk about just the benefits of just bringing us together and looking at aligning together on one set of metrics from a quality perspective. We know our providers are dealing with multiple health plans, always trying to look and align all of these different priorities that we all have that we feel is the most important. But for that provider, they've got 5, 10 other asks. And so what we're trying to do is to align and give them quality measures that are already on their radar. And then also let's work together and get them a pop health platform, which is what we're doing with COSIVA. And so giving them one place, and then along with that, to give them their own set of support through that platform. And so it's definitely an opportunity for us to align all of our stakeholders.
That's great. And we will have more time to talk more about the nitty gritty of like, okay, it's nice to talk about alignment, but what does it actually mean? Like, what were the steps we had to take? What were the things we had to give up? What were the tightly held things that we wished to have happen that might not be happening that we could set aside to go forward? But before we do that, I want to talk about the nitty gritty of the data sharing, because you referenced it, Kimberly. So Con, I'd really like you to jump in here, because we talk a lot about reducing administrative burden on practices and on physicians, but you live reduction of administrative burden every day at COSIVA. It's what you live and breathe. And COSIVA is going to be providing the common platform that allows the reporting of the aggregated results, as you said, payer agnostically. So can you talk about the CAPCI approach and how it reflects the importance of aligning data, and just tell people a little bit more of the nitty gritty of your tools and how you envision it actually making a difference for them?
Absolutely. So the fact that we're all here together talking about advancing primary care in California and the years of work that led up to this point, this work is really hard, right? And we haven't gone through, like you said, all the nitty gritty underneath on all the building blocks to make this possible. But this work and investing in primary care and performance improvement requires multi-payer alignment, requires people, requires process and program and strategies, and fundamentally, foundationally, requires an infrastructure, a common reporting platform that allows for the ingestion of all different data assets and different data types, from clinical data to administrative data, to lab data, to pharmacy, hospitalization, out-of-network information, and data that lives within the EHR, right? So we look at the vast ecosystem of data. How do we make sense of all of that data into information and making it actually actionable for the providers at point of care, and bringing that transparency all the way across, all the stakeholders across the continuum. So COSIVA's role in this place as the common reporting platform, we bring that infrastructure, we bring that platform that allows for real-time performance measurement and tracking and management. Our platform supports all payers, all lines of business. Like I mentioned earlier, the 5 domains of value-based care and many more on top of that. So quality, utilization, patient experience, and having the ability to understand the measurement and who in the population still needs that preventative care, who on my panel still needs that immunization. So understanding the compliance and the non-compliance and having the true transparency and visibility of that information. Then you start to build trust between the providers and the stakeholders and the payers across the ecosystem. So what we've tried to do, and a lot of our focus has been reducing administrative burden in chasing the data, improving that, your score is X, and chasing, we like to say, we want to eliminate chasing data gaps. And we want to recenter and focus the conversation around investments in care, investments in outcome, and strategies for tackling the population that needs that care. So we are the platform that allows for the standardization, the common measure set, the incentive design, all of that to be operationalized in one place for all the participants across the ecosystem. And maybe I'll just, kind of go into one story that touches, I think, a lot around what Janie and Lindsay and Kimberly had mentioned. One provider near and dear to our hearts, practicing in Southern California, independent physician, practices with his daughter and 5 other primary care physicians. What we know is that this provider is contracted with at least 15 other payers across Medicaid, across Medicare, and commercial population. So you're looking at different lines of businesses, at least 15 different contracts, 15 different measure sets, and different portals to log into, 15 different portals to log into to understand what is their existing performance and where and how to move the needle. So imagine already burnout or reducing workforce, increasing pressures of primary care, addressing the acute problem, and then having 15 different ways of how to do quality improvement. Well, I think for what we bring to the table is having that one common reporting platform, one digital front door for that provider, for that practice, one platform to log in to see their performance and and engage in that performance and that work real time. So I think that's in itself is a demonstration of operationalizing the vision of CAPCI into reality.
I'd love to hand it back to you, Kimberly, because that story about the practice, the 15 different portals that they're supposed to go to, and there were moments in this work that we've been doing together in CAPCI, and Lindsay, you may want to comment on this too, where, coming to the decision to pick a single platform was hard. We had to really plow through to get there. But I want you to talk a little bit about, from the plan perspective, like, why would we do that? Why did we come to this? Why did we agree to make those kind of hard decisions? And maybe give the participants here just a little insight into what that was like. How did we get there?
Yeah. Well, and it's funny, Nina, you mentioned that, because we walked in the door with one idea of so many different things. We walked in, and then what has grown is actually the idea of all of us coming in with that perspective. And so, some of us had some experience with doing primary care value-based arrangements. Some of us had not. Some of us were doing it in different ways. So we all understood the reason why we were there. We all understood that we needed to advance primary care. We all understood the value of the primary care physician to improve quality. We knew that. But the way to get there was the challenge. And in those conversations, in those difficult conversations of looking at the platform, one thing that was consistent was the understanding of the exhaustion and the burnout of our providers. That was, and at one point we had a primary care physician come in and share a story with us, and something that really has resonated with me, and said, look, when I have a patient that comes in my office, I may think that they're there for a cold, but they may leave asking me about that. I may find that their blood pressure has risen. I may find that they've lost their husband and they need grief counseling. I may find out that they have no their food sources have decreased, and so all of those things are happening within the primary care visit that may not happen other places. And so to empower that physician to be able to give them not only the resources and give them the access to community resources, but also to invest in their time. And that's the difference. That's a key difference that we weren't doing before. And this is what this work will do.
Mhm. Yeah, it was that value of like wanting so badly to drive change that we were willing to like not just look at it from our own point of view. And Lindsay, I mean, there were some meetings that were tough. Is there anything you want to share around, what you observed as a convener in that process as the health plan sat together and talked it through?
Yeah, I think, there's the light touch approach we could have taken with this, where the health plans could have agreed on a common measure set and attributes and concepts of a value-based payment model, but sort of gone their separate ways and done this separately.
Yeah.
And what was really important to everybody was the more time the health plans invest to coordinate on this together and making it as in sync as possible with a common platform, with common technical assistance, trying to streamline the contract language to be as close as possible. All those little pieces, the more coordinated it is, the better it is for the providers, and it's really achieving the main goal of what we're trying to do. So though it took more time, it's really gonna end up making this a stronger outcome.
Yeah, I agree, Lindsay.
Yeah. Do one of the things we've talked about is how we've talked about individual physicians. I think that story is very compelling. That father and son, father and daughter practice. You think of those doctors that they're at the end of the day closing their charts, and you can really visualize it. But we haven't talked too much about how IPAs or larger medical groups or systems could realize the benefits of this. And Janie, I know IHA has been working for decades with systems and large groups. And do you want to talk a little bit about how we've thought that through and observations or learnings that we have in that area?
Yeah, I think, one of the things that we've done as IHA and as kind of the neutral convener here is making sure that we are linking all the elements of this initiative to the broader environment. So we want to reinforce what is already happening in the broader industry. What is already being applied to IPAs? What are these larger entities out there already doing? So a couple examples of how we've done this, looking at our measure set and how it overlaps with Covered California, CalPERS, CMS, DMHC. We've utilized the same, cutoff points on these measures and made sure that we're listening also to what health plans are already being held accountable for. It's really just making sure that we're not, doing something completely different and new. We're really paying attention to the broader touch points in the industry. We're aligning with OCA. We're in the conversation about primary care spend and committing to align with what is already developed there. So just making sure that, we're not just facilitating, we're listening. We're listening to all the other experts and making sure that we're connecting back to, what is already out there in the industry and how these practices are already, interacting with all these other entities in the industry already.
Yeah, that again, that theme of alignment, that one of the ways we, and all of us, I think, are involved in that it's not just payers, but that the reduction of the noise in the healthcare system we can get there by sharing goals, like let's just work to the same goal. It doesn't make us less competitive, but let's just say that a 5,000 kilometer race is a 5,000 kilometer race. We don't have to quibble about the distance.
And Nina, I'm sorry, just to that point, I just wanted to really kind of just bring home that our IPAs and medical groups are dealing with the same exact issues that health plans are, if not more heightened. because they've got patients right there who are complaining that they didn't get to see their doctors. They've got patients right there that need that intervention. And so if we can take the learnings that we've worked together and also mirror it alongside our IPA and medical group partners, the stronger we'll be.
Mhm. Mhm.
I think
Yeah.
because we all
Well,
want to be in the same, get to the same spot.
if- and we have to, and I think the sooner we can all admit, like, we're on the same side of the negotiating table, looking at the yawning gaps on the other side, the disparities, the cost. These are things that we all have to attack together. So
Yep.
let's look at it that way. Yeah. All right. Well, I have one last question that I want each of you to reflect on, and then we'll get to questions from the audience after that. But I want you to think about, like, reflecting on your own experiences and also what you've heard from each other here today, thinking about how we can expand the reach of CAPCI, because the reach is really to attack those big problems in the healthcare system. That's why we're trying to do this. If you can reflect on that and give our attendees some idea of how other stakeholders can get involved in this work to elevate and advance it. And Con, I'm going to start with you, and then we'll go to Kimberly after that.
Yeah, I think just piggybacking on the conversation that just took place here about how do we get IPAs and medical groups and providers to participate in this work, because like Kimberly said, a lot of the medical groups are also doing this work, right? And so in parallel, we're touching the same practice. So that example that I mentioned of that, physician practicing with his daughter and 5 other primary care physicians, many of those contracts were also, directly with the health plans, but also with the IPAs and the medical groups. So to have all of those arrangements be on one common reporting platform, for all of us to be in parallel and move together on this work in improving access and improving care and population health. So I think that, one of the things I think we all would like to see is how do we get IPAs and medical groups to also engage in this work, because they are doing a lot of this work as well within their provider network. So how do we highlight that and recognize the great work that actually has been invested already by medical groups and IPAs?
It's just a key feature of our healthcare system, particularly in California, just very crucial to driving quality and getting to outcomes and helping move physicians. I know as a physician leader, until we could get data on our whole panels in primary care, nobody wanted to look at quality data because they didn't want to look at it for just this HMO plan from just this insurer that we're in an ACO with. They're like, no, I'm a doctor. Show me my patients, not my insured people. Yeah, that's great. Thank you, Con. Kimberly, let's hand it over to you.
Yeah, it's just exploring that a little bit more. You think about California, especially California, we've got up and down the coast a wide range of providers, of IPAs and medical groups. We've got small IPAs with small practices, but then we have these large health systems. And so if we could find a way to engage all of these different variety of providers and really glean from their experience, I could just sit all day and just listen to our providers share with us what they're experiencing, what they're doing in response to those experiences. Because like we said, we're pretty much doing the same thing, but why not? Let's put some time together to really talk it through. So I'd love to have the same experience we had together as plans, but to do it together with providers.
Great open invitation. So everybody who's listening, tell your friends that they should come and join CAPCI, your provider friends, provider organizations.
Absolutely.
Awesome. All right, Janie, let's send it to you.
Yeah, I think echoing what Con and Kimberly have said, one way to grow this initiative is to invite more stakeholders to the table. So more plans, more provider groups, more IPAs. And it would also be through, implementing this to practices. But I also want to highlight, it's also really consulting with physicians on the backside as well, because we have a wonderful physician consulting group, a group of family primary care physicians that have really helped us along the way. just to make sure that we get the payment model right and that it translates well into implementation and operation. And really thinking through with them, how is this payment model going to be received? Are we getting it right? Are we messaging it right? Are we going out and are we explaining it well enough? Are we making sure that it is something that gets providers excited? So just making sure we're always keeping that voice of, that small, independent primary care practice, physician and care team in our mind, and making sure that we're really creating something that they want to be involved in. And so inviting more stakeholders to the table, but making sure that when they come there, we're listening, and we're making sure that we take their voice into consideration and we're translating it into our program.
I think such a good point. The story that has occurred to me over and over throughout this process is that story of the blind people and the elephant, and that people are so convinced in describing their portion of the story. And it's true, they're right, that portion of the story, they know it inside and out, they can describe it so well. But until people can start to really see like, oh, there's another piece of the story and things look so different. For me, a huge learning was learning about administrative services only. In insurance, like this is a different kind of insurance that I just, as a practicing physician, even a physician leader, I didn't understand at all. But the whole issues around cap payments in that environment, they're different. And so how do we bring all these disparate pieces of the healthcare system? And as Janie said, like, get people to tell their story accurately and also listen to each other so that we can build that fuller picture of the giant elephant that we're trying to walk out of the room. We're trying to walk it into a better place for it than the middle of the room. All right, Lindsay, we're going to give you the last word here on how to involve more stakeholders, and then we're going to move to participant questions.
Yeah, so this phase of the work is focused more on commercial, just to get something going as a proof of concept. The payment model's been designed in a way where it doesn't not apply to Medi-Cal. We would love to see more alignment from payers, aligning either in terms of emphasizing measures that have incentives, or other ways to get creative, but ways that payers can align that'll positively impact Medi-Cal patients also is something that we would like to see. Saw a question come through related to Medicare also. It's not, you're correct, it's not directly focused on Medicare right now, but most of these providers are seeing Medicare patients also. So we keep an eye on, as Janie referenced too, on what CMS is putting out related to initiatives. It's not always going to align because it's a slightly different population, but what they're putting out to see how much can we align as possible with the other patients and requirements in Medicare that providers might see. Also, this payment demonstration project is going live later this year, and we would love to, we're in recruitment, so we would love potential practices or provider orgs where there's overlap with the plans to potentially get involved. And I believe the link was put in the chat where there's more information can be seen. So we open call. We would love for interested parties to get involved.
Yeah, great. And that's real. I mean, you could actually be a practice that's using this payment model pilot and working with us and creating the future of healthcare. Really, we hope. All right. Thank you all so much. We're going to go to questions from the audience. And I think, Janie, I'm going to ask you to start on this one, although all the rest of you, I think, probably will have comments on this. But our panelists are wondering how the payers, literally how are payers coming together to align on the requirements to simplify? And what does it actually mean in practice? Like, practically speaking, what do we have to do to align on measures and incentives and that sort of thing?
Yeah, it's a big question, and the answer is, varied. We're doing a lot of things. We are in constant conversation as a group. So that means we are reviewing the different components and pieces of the payment model and how the measure set will be administered, and making sure that we are aligning on the same core structure for the most important pieces and how it's delivered to the practices. I think it's challenging when you have major health plans which involve, different types of stakeholders. Everyone has different processes and programs and kind of ways of getting things done. And just making sure we're talking through those differences. And the bright side of that is we also have so much expertise in the room. We have, different points of view and different experience, and we're able to bring together, the little key learnings from all of different backgrounds from the different health plans. And we're really able to just make sure that we align on the core structure and, keeping those small independent practices in our mind and, thinking through what it would be like from their perspective. And I'll just say, we've started the recruitment, and I can tell you, like, Lindsay and I have been on practice calls, and we're listening to them as they respond to this payment model, and we're making sure that we keep, those responses in our groups and bringing them back to the plans, and just making sure everything is triangulated in a way that we're consistently refreshing and making sure that everything is sort of up to the core vision, and we're all keeping that North Star in mind.
Lindsay, can you provide a little more detail? Maybe fill in some of the if you and let me just say, there's a lot of legal parameters when you're working in a co-opetition environment. There's a lot of legal regulation that you have to be careful of because you are legally competitors, and so that means you can't share contract terms. I see Kimberly nodding because she's our real contract expert. You can't share exact rates that you're paying, but we can certainly talk about other details around how we incentivize. So Lindsay, do you want to fill in some of the high level and maybe really take it after that?
Sure. So within the payment model, there's two components where the goal is to pay practices more. There's regular population health management payments that come in regularly. And then there's incentives based on strong performance on the measure set. And so what we've all been doing is figuring out between those two components, what is the range of goal to pay practices more, knowing that, so there's been lots of research done with the group through evidence and whatnot, but knowing that it's always going to be a case-by-case basis based on what the practice is currently being paid and a lot of other variables. But in general, we've been trying to agree on a range to increase overall payment, because part of the big goal of this is to increase investment into primary care.
Exactly.
Yeah. Kimberly, anything you want to add, or is that pretty much
I mean, that's pretty much it. And when you talk about the contract and that, just imagine, you guys, imagine all of these health plans. We had to even spend a lot of time on the contract, and they're different contracts. It's not one large contract. It's based for each plan, but we had to work together to make sure that we all kept the same purpose. And so, yeah, it's a lot of work. It's a lot of work.
Yeah.
That we're all up for it.
Exactly. And it's been interesting as we go to uncover new challenges.
Exactly.
We didn't necessarily anticipate some of the things that came up, but learning. It's been a very a lovely example of approaching with curiosity and not fear. And
absolutely.
I was just
one thing that came to mind was how how we came in thinking, Blue Shield, we're excited. We've been doing this primary care. It's really exciting. But then we've got Elevance has been doing primary care themselves, in a different way. And so having to go, I love your example about, coming in thinking that we know, but then having an opportunity to learn others and seeing things from a different perspective. That's been really valuable in the way that we have designed this program.
One of the things that we went into this really wanting this to fix everything, right? We were gonna work on health equity, and we were gonna integrate behavioral health into primary care through this work, and we were gonna create weekend access, and those are. I say those as if I'm joking. Those are all really important goals and things that primary care can do. Does any of those examples strike any of you? You want to talk a little bit about what we saw happening in the process with holding on to those things or letting go of them as we went? Lindsay, CQC has been really big in integrating behavioral health. You know, that's, you want to talk a little bit about where we've gone with that?
Yeah, so I think depression screening is a measure in the core measure set. So that is something that through the technical assistance that's part of this payment demo, the coach will be individually working with practices to make sure they have a process to screen for depression and do the appropriate referrals to help someone get services they need if it's warranted. So it's being played out on the ground right there. I think it's an area that we would strive to, by the end of this whole thing, because it goes for over another year, to take a look at some best practices in that area, to see what plans have already done kind of more broadly in the space, and share some other ideas to be able to expand behavioral health integration beyond just this specific payment model demonstration project, but things that they could bring to other lines of business more broadly.
Yeah, that's a great example. Very practical, right? Like, oh, you can talk at a high level about integrating behavioral health into primary care, but what does it mean to actually train the team to do PHQ-9s on patients at least once a year? You know, how do you train medical assistants to do that? Does it make them uncomfortable? What tools do they need? That's the sort of actual practical change that we're trying to create with this payment that correlates with a reasonable care model.
Sorry, Nina, and capturing that data, right? Capturing that data without increasing any administrative burden is that if the work is done, then automation and systems behind the scene being able to capture that information and report out accurately that depression screening took place. And the providers get credit for what they're doing, right? So I think a lot of that behind the scenes is also incredibly important.
Such a good point. We often think like you can get all the way to, it's that last mile piece, right? Like you do all the work, it's that tree falling in the forest and no one being there to hear it. It's not actually making the sound that we need. And the fact that, you know, it's not a different methodology for Elevance versus Blue Shield versus Health Net. It's sort of you can pull it all together into one platform. We had one question about telehealth, and you know, this initiative hasn't focused on telehealth, but one thing this initiative has done is provided that population health management payment as part of the payment model. And so I don't know, in my observation as a PCP, if I get money that's not tied to a specific service that I'm delivering, then I can sort of use my discretion about how I want to approach the best way to serve someone, whether that's a phone call or a message from my medical assistant or something else. Are there other observations you all have about telehealth? And after that, I think we'll wrap it up.
I think that's exactly right. And I would just piggyback and sort of echo the same sentiment, is that the population health, you know, management fee is meant to be a regular, you know, predictable payment. And we don't want to be too prescriptive about how the primary care practices, you know, have to spend this money. Which is why we've, you know, created this wonderful technical assistance program where the coaches will work one-on-one with these practices to really figure out what is the right area to invest in, or areas. And that could be, you know, more team-based care. It could be focusing on access and, you know, using that payment to invest in those things that, you know, under fee for service, you're not necessarily able to bill for, whether it's phone calls, you know, messages through your patient portal app, you know, it could be a variety of things. And just not being too prescriptive, and just making sure there's flexibility, because really these primary care practices and the coaches are going to know best how to use those funds.
Awesome. Yeah, that idea that we can put discretion back into the hands of the physicians and the clinicians and the teams that they work together with, that to let them do the right thing for the patient based on their knowledge, based on their experience, based on the evidence in the medical literature, that we can use payment to drive that respect towards the practice of medicine. We believe that, yeah, it's going to make a better healthcare system. And one component of that is going to be happier doctors, happier patients, really working together to create more health. So that is the aim of this work that we're doing. You can see, I hope you as participants have seen, not just at a high level that these are ideas that we're engaging in, but that there's some very practical steps we're taking to drive payment that will allow this kind of practice to occur. I am so grateful to work with these amazing healthcare leaders and to benefit and learn from your knowledge and your passion and your enthusiasm. I hope that you as participants have gotten a lot out of this work. I really thank you all for attending. Please be sure that you registered so that you will get a copy of the recording, which you can feel free to share. And you heard the call to action. Join us and think of your friends who can join us to push this work forward. Thank you all so much and have a great rest of your day.
Thank you.
Thank you.
Take care,
Thank you so
everybody.
much.